So in this, I am going to share a work that we did where we're trying to use one of these technologies that have been innovated by researchers like you and trying to see how they help us in real life. Because when we do this great work, the models and whatever we're doing, if this don't really translate into real life, then that great work will still remain with the question, so what? So I'm going to share with you, this is, we are going to use a phone. We're using a phone to monitor adherence for TB. And so the study we did with my colleagues from University of Georgia in the US and colleagues from Makere University is entitled Video Direct Observed Therapy, which I'll be calling VDOT moving forward, for supporting and monitoring adherence to TB treatment in Uganda. So this was a pilot randomized controlled trial. I think these are different kind of approaches when it comes to this audience, but I guess we know all this. So just some bit of background. TB is a very ancient disease, but it has still persisted up to now. And yet the cure is there. Majorly, TB is cured. And so until the coming of COVID, TB was the leading cause of death from a single infectious disease. And so treatment usually at a minimum can spend 6 months. And so adhering to treatment is very important for good treatment outcomes. And so therefore getting patients adhere to the treatment is very important in order to achieve the WHO and the UN TB end strategy, the end TB strategy, which is about ending TB by 2050. So when patients don't adhere to treatment very well, so there's increased risk of death from the disease, relapse of the disease, but also chances of developing the drug-resistant type. You've been, addition took us through antimicrobial resistance. And so these are issues we are dealing with. Organisms that were really susceptible to the antibiotics we had before now become resistant and so more difficult to treat and so more likely to die from them. And so drug-resistant TB is very hard to treat. Patients with that are more likely to die from it because even the drugs are really more toxic. And so it's important to foster good adherence to this treatment. Some of the reasons for poor adherence could be stigma. TB is a very stigmatized disease. Side effects from the drugs, but also social aspects that affect especially this group of people who are usually poor, the costs involved of that. And like I've said, TB treatment is about at a minimum 6 months. And so from the start, WHO made sure that put in strategies to make sure that adherence to the treatment is really good. And for example, if one is put on just a 5-day course of antibiotic, no one, I think in this room, not many would adhere to 100%. So imagine treatment for 6 months, then people are more likely not to adhere that well. So strategies were put in place by WHO, and one of these, in order to foster good adherence, and one of these is to have this treatment observed, that they call it in-person observed treatment. So as a patient takes their treatment, every dose for the next 6 months should be observed by a person to ascertain that actually the medicine has been taken. However, they've been concerned about this in-person DOT, which I'll be calling DOT moving forward, that is direct observed therapy or treatment. They've been concerned about concerns about this as one of them being impinging on the patient's autonomy, their privacy, but also some studies RCTs have done, and they've compared that those who really take the medicine on their own self-administered therapy versus those who are on DOT, in-person DOT, really the outcome are not very different. But like I said, WHO knows that there are patients who are problematic. And so this is a recommendation from WHO that observed therapy should be the way to go when you're managing TB. And so there have been innovations around using digital adherence technology, using the technologies that we have, digital technologies, trying to see how they can substitute for the in-person observed therapy. And like this in-person observed therapy involves a patient going to a health facility every day to be observed by a health worker, or it could be a community health worker who comes to the homes of the patient and observes them take the medicine, or it could be a family member. But you can imagine every day, this doesn't become feasible in real life. So innovations around using digital technologies to come in and substitute for that in person have been found to have a promise in doing that. And these are some of the technologies that I'm talking about. If you look at that is a phone, a feature phone, ordinary phone, and below it, there's a blister pack. These are pills in there. And so what happens here is that when a patient opens this blister pack, a message is sent to the facility, and that mere opening means that the person has taken the medicine. The patient could throw away this medicine, but it's a proxy that the patient has taken the medicine. Then we have B. B is the VDOT I'm going to talk about. So here the patient takes a video of themselves taking the medication, and this video is sent to the health facility where the health worker looks at it, and then it's recorded that the person has taken medicine. We have a digital pill box. Now this digital pill box, every time the patient opens it, also a message automatically is sent to the health facility, and it's also a proxy that the patient has taken medicine. There are also advanced innovations of ingestible sensors. So the tablets, the pills are wrapped with sensors. And so when the tablet reaches the gut, then a sensor as a message automatically is sent to through this system and to the facility, and it shows that the patient has taken treatment. But what do these exactly do? These digital adherence technologies, this is the function they actually do. So one is that they are reminders to patients to take medicine through sending of messages, as I'll show you later. They facilitate real-time or asynchronous observation of medication intake, because this message is sent to the health worker. He can see it in time, or she can see it in time, but at any, or even later, but it's confirmation that the person has taken medicine. A proxy, because one can open a blister pack and they never take the medicine. And this information that is sent is later then used to compile the patient's dosing history. And so then you are able to tell from that history that this person has been adhering well, I don't need to, it's okay. Or this one has a problem, I need to pay attention to this patient. And so this helps in triaging of patients and see whom to reach out for who are problematic. And then the rest who are doing well, you can leave them on their own. So evidence has shown, especially with the VDOT that I'm going to talk about more in detail, that this was a systematic review and looking at these digital adherence technologies in trying to increase rates of treatment completion. And it was found that the VDOT versus the in-person observed therapy was really good in fostering high treatment completion rates. But this is a study, this is another city in UK, another in the US, but this evidence is mainly coming from the high income countries. Yet the burden of TB is more in the low income countries, though I know even, of course, this is like, they were talked about malaria, how it had been eradicated. It was eradicated in Europe, but for TB, it was initially eradicated, but now there's a resurgence, a recurrence in those high income countries, and it's because of these movements, because we're in one planet. And so that the evidence now seems to be coming from the high income countries and little from low income countries, yet, like I've said, the burden is more in those countries. So there's been a call and appeal to do more research, more robust research, especially in the low-income countries, to look at the effect, the acceptability, and the cost-effectiveness of these digital adherence technologies. This is the policy underpinning from WHO. The bit in yellow is where it says video observed or VDOT may replace in-person DOT when the video communication technology is available and it can be appropriately organized and operated by the health worker. So there a policy background to this. So this is the experience I'm going to share that we did. We had a pilot study where we tried to look at the effect and the feasibility of implementing VDOT. VDOT is the video one, and these were the study objectives. We wanted to understand the perceived barriers or benefits of this technology in the stakeholders, and this included patients, the health workers, but also the policymakers. When you're dealing with human beings, these are social beings. So we bring in the social science bit of it. You need to first understand their views about what you're going to do, and that's how you can come in with an intervention that fits in well within their expectations. So we first did that bit, and then after that, we implemented another CT, a pilot, where we looked at the effect and the feasibility of conducting this VDOT, implementing this technology. So these are the stages: the qualitative study, where you interview people, we don't count numbers here, you're trying to get the variation in the views of what they are talking about, then another CT, and then finally we had an exit study, still qualitative, try to understand how acceptable and how feasible this was. So this is just to take you through the overview of the VDOT. So it's a mobile app, where the app is used to record the videos. Then it has a messaging system, which is used to send the messages. Then there's a desktop system where the health worker downloads and looks at these videos and then does, the review and then can make judgment of this. So that's the phone with the app. We use the Sure Idea app. This was developed by colleagues from San Diego State University. This is the patient. They bring out the drugs and they take the picture and they show everything should be very clear. And so after recording the video, then they upload it in the cloud, and then it's saved in the cloud or local server. But this video is date and time stamped, it's encrypted. And then when it's uploaded, then later is downloaded at the desktop of the health worker, who now just views these videos and can tell whether the patient has taken treatment. And so the thing is that if the patient doesn't send the video, then the assumption is that they didn't take that treatment. That's really the assumption. So initially, like I said, we did the qualitative study, quickly take it through what these stakeholders felt as could be the barriers in terms of bringing this technology to help them in terms of monitoring patients on treatment. So there was a feeling that there will be increased workload when you bring in this. These are now health providers, and this is the reason that they felt that they would need more staff to be able to review these videos. It's a lot of data coming in. So they felt that with the current staff they had, that would be not enough. So you need more staff to be able to review all this data coming in. Lack of equipment, so infrastructure issues, lack of computers in the facilities in our setting, that was an issue. And also those were felt to be a barrier. Then from the patients, there was a fear of not being able to operate a smartphone. Some of these TB patients are very poor. They might not even have ever owned even a feature phone. And so here you're asking them to operate a smartphone. So this was a fear. Then also there was a problem of, there was a fear still from the patients of the safety of the information that they'll be sending through. They felt there could be voluntary disclosure. This information could be misused. Well, the next day you find this patient on a billboard advertised. And so, and TB being a very stigmatized disease, that was a very big concern. From the policymakers, also it related to the workload. They felt this would bring in a lot of workload. And so they were saying that this can only work if this system is automated. You're talking of artificial intelligence. I think this is what they had in mind. Automation to review these videos. And then also other concern from the policymakers was that it will cause inequity in the services. So like in our setting, you find internet coverage is not the same all through. So that means those people who have good internet and can afford a phone will be the ones to use such a kind of technology. When it comes to, so these are the benefits. So the other ones were barriers, but now the benefits of this technology, confidentiality was raised as one of them. So as I told you that DOT, in-person DOT is what WHO had recommended. And so TB being a very stigmatized disease, that you even find a family member not disclose, so a patient not disclosing to their family members. So if you're talking about someone coming in from out to observe them as they take treatment, that now impinges on their privacy. And so they felt if this technology is brought in to monitor them as they take treatment, would now make it more private. They don't need to be exposed to that because that technology now will promote privacy. They don't need to be observed by any other person to be known by their own treatment. And then the other thing was that it gives timely follow-up of the patient because you're sending a video, you're sending an SMS or this click of the message as you take the medicine. It goes and the health worker is able to tell that actually this person has taken the medicine because the video going, it's a proxy that the person has taken medicine. And usually, like I've said, this treatment is for 6 months. So when there's enough supply of drugs in the facility, then, and for stable patients, you tend to give them like a supply of 1 month. So if you don't come in early, then someone might come after 1 month when they haven't been even taking the treatment. But with this, it was felt that you'll get real time to identify those who are problematic in terms of adhering. The other bit was patient-centeredness. This is a WHO concept that is now being promoted, that patients should be at the center of their care. So they felt this, a patient being involved in monitoring their adherence and doing this would definitely promote this. And yeah, basically that was the qualitative. But now to the RCT. When we implemented the RCT, we screened 222 TB patients. We excluded 84. Those are the reasons. And then we had 2 arms. The control arm, this is the control arm. We had 72. So here they are receiving the standard of care. What is happening in the facility? What was then happening? And then the intervention is the people who received the VDOT, the phone with who are going to be taking the video and sending the videos to the facility. So these are the intervention of the people in the intervention arm. They were given a smartphone. If they didn't have, then we had to install the VDOT app on their phone. And then they were being sent SMS messages reminding them to take their medication. Then also gave them data weekly to make sure that they are able to upload the videos of what they're taking their medication. Otherwise, it will be a problem. So these are the baseline characteristics. I can ignore this slide and move to this. So here, this is what we came up. This is the outcome. So in the first graph, so here it's looking at observed videos if it comes to the intervention arm. And so here the dark bars, those are the videos that were missed. The lighter bars are videos that were received. So this is the intervention arm, the arm that received the video, the VDOT. And you find that there are less of the dark bars and more of the lighter bars. Now, when you compare it with the standard of care, where patient is assumed that they should have gotten someone to supervise them and they take treatment. So here, this is self-report, and people are telling us which doses that they were taking were actually observed, as this will be a proxy that they took treatment. So the doses that are not observed are the dark bars, and the ones which are observed are the lighter ones. So you find more of the dark ones. And so if you are to use this as a proxy for adherence, then you'll take it that the people on the usual care, on the standard of care, are not really adhering well. And probably this could also be because that in-person DOT is not feasible. Perhaps patient could have taken the medicine, but maybe the one person that's supposed to observe wasn't there. So using that, so we go on to see our main outcome. We looked at fraction of the fraction of the expected doses they were supposed to take. So 80%, this was a binary outcome, 80% and above is good adherence. So if you look at this here, so patients who took less than 80% of the expected doses they were going to take, you find this is the column for the standard of care. You find that 90% of them were falling under that, using the other measure of whether the doses were observed, as compared to when we used the VDOT, the app. So using this, it shows that, I'll go to that. So we just dived in a bit to understand this technology. I mean, why videos were not coming through. And we found that because I showed you a bit of the videos not coming through for the VDOT arm, and 50% of the reasons of the people who didn't send their videos, it was because of the technology, either the battery was down or the phone was stolen, but it was more of the technology than the 37%, which was through because of patients. So summary of this, what we got from this pilot, we found that 30% of the expected doses that were observed for the patients who were under the standard of care, they had 30% of doses observed as compared to 90% for those who were sending in their videos. And so this gave us an impression that using what measurements we're using, using DOT, patients were more likely, 8 times more likely to have taken their doses as expected as compared to those on standard of care. But also to share with you, and this is the qualitative we did after, trying to understand what could be the feasibility or the challenges that were affecting the actual sending of these videos, or using the technology in this setting where technology is not so common, especially in the patients, poor patients. So one of them was internet network being down. That was a problem. They were worried about theft of the phone because they would not move with them. So they were going to work because this is a phone that was from the facility and they were expected to check it back after the treatment. They talked of that too many reminder messages, which were sending them to remind them about taking medicine, and they felt that was brought in fatigue and they didn't like it. But also the challenge with the messages, they felt that anyone could access their phone and this would lead to inadvertent disclosure of their TB status. And then also problems of getting a private place to take the video, because still, like I said, TB is a stigmatized disease. So if someone sees you taking videos, you're taking medicine, so they would always have to struggle looking for a place which would be private to take the videos. So in conclusion, we just want to say that from this study, we thought that VDOT was giving more favorable, terms of observed outcomes in terms of observing treatment as compared to the usual care, where a person should observe the patient. And the other thing is that what seems to be coming out is that this like VDOT could now be used or are important in fostering or enhancing patient-centered approach, which is really a key concept now that is promoted by WHO. But as a recommendation from this and future work, basically these tools, the VDOT and even the other ones I've already shared, this just help to monitor adherence, but they don't go further to say, these are the reasons and interventions to address the challenge, the causes of non-adherence or poor adherence. So actually, from this data that is coming from these monitoring tools, one then should be able to understand the data, looking at the history of the history of the compliance, or the history of how they are complying, and triage these patients. And those who are problematic, get closer to them, try to understand the medical, the psychosocial or cultural or structured systems that could be causing the poor adherence, and then come in with intervention. So they don't really solve everything. It's just helping you as a tool to be able to triage and know the problematic patient and see how to closely deal with them. And then the other thing is that still I presented a number of them, the 99 dots, the VDOT, and the issue about VDOT was being that some people they can't afford, or where there's poor internet connection. So the move then is to have differentiated service models. And here you just use the tool that works well with which population. And so you can have a combination. You could say in a urban setting or the rich, they could use VDOT. The poor ones, you could use the 99 dots that way, so that all of them across, you are able to provide these tools to monitor adherence. And then, of course, like what came out from one of the policymakers was the issue, workload was an issue. And then one thing was about how to, this data, a lot of data coming in, how you don't have health workers read it. So we're thinking of using AI, to be able to come in and help and read this data, interpret this data, and then health workers can come in and do the triaging based on this. So these are the publications we made out of this work. It was simple work. We appreciate funding. Just have to acknowledge this there, and most especially the funding from NIH. Without this funding, we wouldn't have done this work. Thank you very much for listening.